Hi everyone, welcome back to the Chatty Vets Podcast. I'm Brendan.
And I'm Charlotte. Thank you for tuning in. So we're back again today for our second part of our dyspnea episode. So we're in our bonus episode, Clinical Deep Dive into Dyspnea. So in the first part, we covered what you're going to do when these patients present to you in the clinic. How are we going to start to have a good look at them and work them up? So we started speaking about POCUS, and that's where we ended up finishing off. So I think today the first thing that would make sense in this episode is to finish off our POCUS exam and then go from there. So last time we covered pleural effusion, we covered pericardial effusion, and we covered wet lung and our B lines on our POCUS. But maybe the next place to start is when we're looking for pneumothorax. So we've spoken about pleural space disease in terms of fluid, but what do we do when there's air? So if there's pneumothorax, what are we expecting to see, or what are we looking for on our POCUS, Brendan?
I think the first thing to say as well, by the way, is this is the hardest part of the TFAS possibly, and it's the most subtle and difficult. It's not that common to get pneumothorax. So can we just say, don't get too hung up if on your first few POCUSes you can't do a glide time, and you just have to lean on how did you do this before you did an ultrasound, The other really key thing here is if you see B lines, you've not, in that where you are with your probe, you have not got pneumothorax in that site, because you won't, because the pneumothorax is air just between the lungs and the chest wall, and it will get in the way and the beam won't be able to cross that air. It all get reflected. So you can't see B lines, you can't see wet lungs. So if you see B lines, you don't need to be thinking, is there a glide time there? Yeah. So yeah, is that kind of how you see it too?
Yeah, definitely. It's a quick, easy way to check. So when we talk about the glide sign, and we'll go into depth as what that is and what to look for, basically it can be really tricky to look at. It's really subtle. The majority of T-POCUS is quite simple and it's quite easy to see, but I think the glide sign can be a bit tricky. So, but if you are seeing B lines, you do not have a pneumothorax in that area, like Brendan said. So use that in your arsenal to say, okay, I can be pretty happy that even if I'm not sure about what I'm seeing in terms of the glide sign, if there are B lines there, I'm happy. There's no pneumothorax. I can tell that there's wet lung. So yeah, that makes a lot of sense.
I was going to say, I've never lent too heavily on my TFAST to tell me about pneumothorax. I think by the time I've excluded wet lungs and pleural effusion and stuff, I might well be at the point where I might be radiographing if my patient's really bad, or I might be, it's a dog with major trauma and pneumothorax is coming higher on my list, and a DV radiograph might be helpful.
Yeah. I think, to be honest, I sort of stick by what I said last time in terms of if I have a dyspneic patient, like a patient that's really struggling to breathe, I still never think it's the right idea to put them in lateral to take an x-ray. I don't recommend it. A DV, like you say, when you're not stressing them, by them just sitting in sternal on an x-ray table is a little bit different. But for me, to be honest, normally, even before I put my probe on, you can generally tell when you're expecting a pneumothorax, even from clinical exams. So one, you're suspecting trauma the majority of the time, not always, but the majority of the time anyway. And if you've got muffled sounds dorsally on both sides of your chest and they're struggling to breathe, I'm going ding, 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 pneumothorax even before I've put the probe on. And then if I'm not seeing B lines and if I'm struggling to see my glide sign, for me, that's, again, enough of an onus to be putting a needle dorsally into that chest anyway. So I think, yes, don't get me wrong, for the more subtle ones where they're not dyspneic and they've possibly had trauma and you want to check what's going on, yes, I think that you can catch the odd pneumothorax on radiographs and they're easier to see in some respect. But I just think that, but those are the ones that we wouldn't be draining anyway because they're not causing dyspnea. So I think ultimately I still stand by that. If you have a dyspneic patient, try your utmost to see it on ultrasound first, because even if you have a hint that there's a pneumothorax, I'd be sticking a needle in before I go lying it in lateral. So that's my take home, I guess. But anyway, maybe we've harped on about the glide sign a little bit already, but what is that? What are we looking for when we're looking at a pneumothorax?
Look, I think machines vary a little bit, and you'll get to know your machine, unless you're like us, we're constantly using different machines because we're locuming. But it's a shimmering of the pleural membranes as the patient breathes. So that little movement of the pleural membranes, the pleural membrane against the lung and the pleural membrane against the inside of the chest are rubbing against each other every time the patient's breathing because the lungs are moving. And it causes a little, now, so many ways you describe this. You can think of it as like a shimmering right at the top of the screen, right between you. You're looking between your ribs. You've got that sharp white line. And just at that point there, you'll get a shimmering. I like to think of it as ants. And they're like little like white ants, and they're all like moving with the breaths. So if the breaths are fast or slow, they'll move fast or slow to and fro in that space between the ribs. And I'll go, oh look, there's the ants, and then I'll know if that's my glide sign. If I can see the pleural membrane shimmering, the ants moving across, I haven't got air in the pleural space, because that's the visceral and the parietal, pleural, it's coming back to me from 25 years ago, moving against each other. But if there's air in the space between those membranes, we're not going to see that shimmering at all, and we'll have no ants. So how does that description fit with what you see?
Yeah, I think it's a really good way to describe it. I mean, I see it as like a glittering, which is shimmering, same thing. It is like the pleural line. So that bright white line in between the ribs glitters, and you can see it moving. It's subtle, and don't expect it to look like an ECG, and it's not going to wobble all over the place. It still stays in a line, but it glitters and it shimmers and it moves. And that is really normal. When you have a completely static line, that is when you know it's abnormal. And I guess one tip that I would say is that if you're looking for it and you think, I don't think I can see a glide sign there, check ventrally on the same chest, because it is very, very unlikely that even if you have a massive pneumothorax, it is incredibly unlikely that every single point within that chest, you're not going to see the glide sign. You will probably, in the majority of cases, be able to get really ventral and see it supraventrally, because air's going to rise, right? So you're going to see it dorsally. So the majority of the time, if I'm ever like, is it a pneumo? Is it not? Check ventrally, because I've always gone, if I can see a glide sign ventrally, but dorsally it's disappeared, I'm happy. There's air in there. Let's get a needle in. So you can use that as a bit of obviously there's going to be the odd exception where there's so much that you're not going to see it anywhere. But to be honest, I think those patients would be so dyspneic and you'd hear no lung sounds. So you'd be pretty certain before you even pop a probe on. But yeah, I think that's my sort of top tip really. And I guess the way that you can also take that is when you get really good at being able to see it, you can also use that to track a pneumothorax. So say, for example, you do a scan and you're starting dorsally and you work your way ventrally. When that glide sign comes back, I sometimes mark the patient's chest, like actually use a Sharpie or something like that initially, especially in like your trauma patients. Mark it, because then you can say, okay, this is where it came up to. Drain it, or for example, if you've got a patient that's not dyspneic and you're saying, okay, I'm not going to drain it, but I know it's there, you can then track it. So is it getting worse? Is it getting better? After you've drained it, where does the glide sign come back? Have you still not got a glide sign supradorsally, or have you got rid of the whole thing? You can then physically see where the pneumothorax stops and starts. So it's quite good to track the progression of a condition as well when you get good at being able to see it. So does that make sense?
That's super. I think you're the pneumo draining queen here. I've only done
No.
what? I don't know how many I've done. Not many, a handful.
No. To be honest, I think I track them more because, to be honest, a lot of the pneumos that I see, I don't drain, because a lot of them have come in after trauma, like an RTA or something, and they're not dyspneic, but I can tell that I've got a pneumo. So the ones that you have after trauma like that, you might know that there's a little bit of air in there, but it's going to get resolved. It will go on its own. So if it's not causing dyspnea, don't cause more trauma by sticking a needle in. Track it, make sure it is reducing and that line is getting more and more dorsal, so the air is reducing. And the good thing with that is that if it's getting worse, you can tell, because if you're drawing your line more and more ventral every time you check, the air's increasing. So it's just a little tip to say, how you can keep an eye. So, but there we go.
Okay, that's glide sign. Do you reckon we've done it?
Yeah, I reckon so. Perfect.
Okay, next one.
So we've spoken mostly about everything we want to check with the lungs, but I think now we're on to what people perceive as the really scary bit. So if you're not used to ultrasounding a chest, the thought of scanning a heart is horrible. And I remember the first couple that I scanned, first few that I scanned, I thought, oh my God, is that normal? Is that not normal? What am I expecting? Blah, blah, blah. But I think I did the silly thing of learning how to do it in an emergency clinic. So I was expecting abnormal. But then because I didn't know much about normal, I didn't then know whether things were abnormal or not. So I think the biggest tip I can give you is if you have a really good patient that's going to be happy for you to just do a quick T-POCUS, it will take you 10 minutes. Just pop a probe on, learn what is normal, so that when you do have a case where you need to know whether that heart looks normal or not, you've got comparisons. When we're talking about what we want to look for in T-POCUS, in terms of an emergency sense, you don't need to be a cardiologist. You don't need to be able to say, that's got a really inflamed or thickened mitral valve, or it's got aortic stenosis, or the whole purpose of it isn't to diagnose what condition that animal's got. It's, does it have an increased left atrium to aortic ratio, i.e., is it in congestive heart failure, or what's its contractility like? Is it beating in the way that I'm expecting it to? They're the two questions that I want to answer. So I don't know if you're looking for anything else, Brendan, when you're doing a cardiac scan, but for me, they're the two things I'm looking for, really.
Yeah, we have this really neat, possibly oversimplification, but it's an oversimplification that helps us tremendously in that the left atrium has to be fairly reasonably enlarged if we're going to get cardiogenic pulmonary edema, if we're going to get heart failure, basically, as the cause of our wet lungs. Or our pleural effusion in cats. So, and the other nice thing is in cats, because they're the typical ones where we have got the urgency, the left atrium will really need to be, in the vast majority of cases, at least twice the size of the aorta than it normally is. So it gives you a little bit more room for error. And oftentimes, I don't know how you find this, but there's so many times I'll scan a cat and it's enormous, the left atrium. It's as big as the
Yeah.
ventricles or whatever. So,
Yeah.
you don't even have to be that fancy. And it doesn't mean it's definitely the cause, but that is consistent with a patient that could have the cause of its wet lung could
Yeah,
be the heart.
exactly.
And it nearly always is the case.
Exactly. I think ultimately when we're looking for LAAO, which is your left atrium to aortic ratio, when you're looking for that, basically pop the probe just caudal to the right elbow on the chest. Once you get the heart beating, top tip is tilt the notch of the probe that's facing cranially on the patient, tip it towards the elbow. So you're going kind of diagonally with your probe and then pan forward towards the head. And then that should give you that cross section, your Mercedes-Benz sign of your aorta. Have a little play around, but you should be able to see that if you're in that kind of area. And I guess once you've got that view, like Brendan says, if you're struggling to say, is it enlarged? Is it not? Maybe I should measure it. It's not dying of congestive heart failure, basically, is what you need to take from that. If your left atrium is big because your patient has got congestive heart failure and it is in an emergency state because it's got cardiogenic pulmonary edema from a failing heart, the majority, obviously there are exclusions, don't get me wrong, but the majority of the time, that left atrium is so big that you look at it and you go, well, that's definitely enlarged. I don't even need to measure it. It looks 2 to 3 times what you're expecting. Or especially in cats, they're normally massive, aren't they, when they
Yeah.
present at that point?
Yeah, I think they are, but I think you could potentially have a moderately enlarged left atrium, so it's not that massive, and severe dyspnea. I think the biggest thing I find, and tell me if you get this as well, is getting a nice view of the heart. And to get a nice view of the heart, because we're in sternal, if we had the table with the hole in it and we're scanning from below, easy, because the heart will drop down and
Yeah.
you're scanning from below the patient, so the heart is now sitting on top of your probe. It's really easy. We often do this in sternal, and basically the heart isn't sitting against the chest. And as soon as we get air-filled lung, it's going to block our beam and we're not going to be able to see. So we have to get the heart to fall against the right side of the chest. What I do now, look, I need 3 hands to do this. So if I can't get a nice view, because the heart's not that enlarged actually, I will cup the chest of the cat and I will tilt the cat. So I've got my probe on the right chest wall. I've got my hand on the sternum, and I'll usually have my nurse saying, "Oh, can you freeze it when I get the image?" Now, it's not in lateral. It only needs to be 10, 20 degrees across, but straight away my heart is now just going to fall against the right chest wall a bit more, and it will improve my view. Is this
hmm
an issue you get into?
I think, to be honest, I find it less so with cats because I often find that there's not much space in there anyway. And if they're dying of congestive heart failure, then it's quite easy to see their hearts, to be honest. I find it more so with dogs, especially if they're panting. I find it quite difficult to see. But honestly, we scan chests every day, or at least if we're working in emergency, we do. But there are still the odd case where I look at and I'm like, oh my God, I just cannot get a good image. It's really frustrating. And if that happens, just take a step back, take 5, 10 minutes, do something else, use your time constructively, but then just think, right, okay, I'm going to go back. And often the patient has just moved a little bit more, moved their leg out the way, or they're tilted in a slightly different direction. And sometimes you just get such a better view. So don't kick yourself if you can't find it. It's probably situational. Give yourself a second. And remember, you're probably going to be panicking and trying to check quickly as well. It's frustrating and it takes time, but after a while, once you've seen a few normals, it's usually really quite easy to be able to get to the point where you're saying, I can be pretty certain that that's enlarged. It's not often that I'm having to measure them.
I think you do need the nurse, hopefully, to be pulling the right foreleg forwards a little bit, because
Hmm.
that elbow forms a perfect shield for where you need to put your probe. And if they're not,
Yeah.
and obviously these are sometimes arthritic cats as well, so you have to try and do it in a more delicate way so you don't upset the cat
Mm,
and then it's resisting you and fighting. So, but you
yeah.
need that elbow about an inch and a half forward so you can get right where that elbow was to scan the heart,
Yeah.
don't you?
100%. Yeah, 100%. And sometimes I find I can do that with the same hand that's holding the probe. You sort of use a couple of fingers to push it out the way gently. But if it's a dog, especially, yeah, you're going to need someone properly extending that forward for you to get it out the way. Perfect. So we've had a little chat about left atrium aortic ratio. I guess maybe it's subjective the way that I do it, but the other thing that we're always looking for as well on a T-POCUS is cardiac contractility. Now, I am not a cardiologist. I am rubbish at checking I can't even remember what the equation's called. There's the thing where
Fractional
you can,
shortening.
yes, fractional shortening, well done. And you can measure it and work out exactly what the number is in terms of, is it normal or is it abnormal? But for me, in terms of an emergency sense, I basically want to know, does it look like the heart is pumping effectively or not? Now, again, once you've seen quite a few normals, if you have a septic patient whose contractility is crap, or you've got a DCM patient whose heart is barely moving, it is so obvious. You will literally look and go, God, that's not moving. Where's my pivot bend, Dan? I don't know if you do it differently, Brendan. You might be a lot better than I am and measure your fractional shortening and things, but I know that I definitely don't.
No, I'm definitely not better than you at that. Do you know exactly what you said? I totally agree with it in every way because there's been so many times I've done a cat. I've looked like just like what you said. I've looked at the heart and I look at the cat because I can't see the heart barely contracting. It's
Mm,
terrifying, and I look. Hang on, it doesn't look that bad. You like just check it. No, it's still alive. It's fine. But yeah, it can be
yeah.
dramatic. And this is a really good example where, as GP vets and out of hours vets, we can chat on and go, but we're still helping our patient, aren't we? Okay, we can't do it as well, but the patient's not fit to travel and we need to make decisions. And actually, the really, really marked ones, yeah, okay, that's going to be clinically useful. So we have to, it's a great example where, yeah, we're not perfect, but yeah, if it's
Yeah.
really obvious, and sometimes it is,
Yeah,
yeah,
exactly. And
right.
and I think, the reason why we keep banging on about POCUS so much is that all of these things give you so much information from doing a quick, and it probably takes what, 5 minutes to do a good T POCUS, would you say? Generally 5, 10 minutes. But you can say, is there a pneumothorax? Yes or no. Is there a pleural effusion? Yes or no. Is there wet lung? Yes or no. Is the heart contracting in the way that it's expected to? Yes or no. Do we have evidence of congestive heart failure? Yes or no? They are 5 massive things that will completely change what you do from there. And it gives you so much information. You've not stressed the animal out, and it's not that expensive. And you've not had to do anything in terms of giving them drugs, etc., to try and get all that information. It's once you get used to it, it will literally change your life. So just, I think the thing that we would say is just practice, 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 because it is, if you can get good at it, it is an invaluable tool to use on these emergency dyspnea patients. So,
I would say there's a mindset change as well because I've noticed going back into
mm,
general practice, when I do an ultrasound in general practice, I'm trying to be super thorough. You haven't got the justification of lack of time to the client. So you really don't want to miss things. You want to try and be as thorough as you can and be good. But with emergency, the mindset is different. Like you say, you're just trying to get 5, 10 minutes, get enough of an idea to get the treatment started in the right direction. It doesn't have to be a perfect job. And in an
mm,
emergency, you don't have to document all the lovely images and da-di-da. You know, sometimes I'll go, oh yeah, that left atrium is really big, but I didn't quite get the pause the thing at the right time and I haven't got an image. It's an emergency situation. It's a different thing. I think the mindset can be much more, yeah, I've got a rough idea that was, whatever. Let's move on now because that's going to direct my treatment. Is that,
Yeah.
do you notice that difference in mindset?
Yeah, and I think, to be honest, I had a case when I was locuming day practice probably a couple of weeks ago now. There was a dog that came in whose inspiratory effort was just a bit more than normal. It wasn't properly dyspneic, and the owner said it had been fine at home, but it had been losing weight. It was an older dog. And I said to the lady, she didn't have a lot of money, but I was like, look, I can do you a T-POCUS pretty cheaply. And I said, don't get me wrong, it's not going to tell me if there's tumours inside the lungs or something like that going on in terms of the pulmonary parenchyma, but it's going to tell me, is it heart related? Because she said the dog had been coughing a bit. So I was like, is it heart related? And if it's not, it's going to tell me that there's probably something more going on in the chest that's, one, is going to be more money to work up, and two, probably isn't going to be a great prognosis in an older dog like that. So I think you just need to think about the way that you're explaining it to owners. If you say, I'm going to do a chest scan and I'm going to scan the heart, they're going to think, great, we're going to get a diagnosis as to exactly what type of heart disease it is and what's going on. Whereas if you say, I'm not a cardiologist, but what I'm going to be able to tell you is the big things that we need to worry about. Is there fluid where it shouldn't be? Is the heart working the way that it should be in terms of a general sense? And is there evidence of heart failure? If you can rule out those things, then it gives you a hell of a lot of information. So I think it's just the way that we speak about it to owners. And like you say, the mindset of what it's doing. It's not going to give us all the answers, but it gives us all the answers we need to know quickly. Does that make sense?
Yeah, I like that. People who hate ultrasound are going to hate this episode, aren't they?
Yeah, I know. Oh, well, we apologise. Hopefully we've made you like it. Yeah.
Oh, no.
Okay, so we've covered our basic T-POCUS, but maybe the thing that we need to discuss at this point is, what do we do if your T-POCUS is normal? So if you've got a dyspneic patient, okay, majority of the time we're expecting to see something on a T-POCUS, right? We can say we think it's congestive heart failure, or we think it's got a pleural effusion, or we think it's got a pericardial effusion, or whatever, or we think it's got pulmonary edema or pulmonary contusions or whatever from your POCUS.
Normally that's when, if it's a cat, I'm going, is it asthma? And I'm going back to the client and have the cough. Is it a cough? And then they'll go, well, she does this. I go, that sounds like a verbal. If they're making a really loud sound, you can hear from another room for a minute. That's a verbal. They're trying to retch up. If it's just a little subtle little cough, it's just in a cat. It's often just a quiet little cough, just little, and that's it. It's quite different from retching a verbal up. Usually, I'll get it's been coughing like that either seasonally or year round for a couple of years. So it's normally a really long history. Dogs, then obviously we're radiographs. Well, we're if it's a Westie, you might go pulmonary fibrosis. Yeah, go on. Tell me other ones. What else have we got?
Yeah, I guess, to be honest, at that point, you're thinking, right, okay, it's either something in the pulmonary parenchyma that which you just can't see because there's no fluid in there. But for example, if it's got tumours all over its chest, you're not going to be able to see that on an ultrasound probe, because if the superficial lining of the lungs is okay and you've got air in it, you're just going to reflect your ultrasound waves. So I guess is it a true pulmonary disease, which you just can't see? Is it airway disease, like you say, or upper respiratory problem, like a upper respiratory obstruction or something like that? But I guess the other one to remember, which really used to catch me out when I first started doing emergency, is your respiratory lookalikes. So your patients that look like they're really dyspneic and they're breathing awfully, but there's actually nothing wrong with their cardiovascular or respiratory systems. So the biggest one that I find is your DKA cat. So when you have a cat in diabetic ketoacidosis, because their blood becomes so acidic because of the ketones, they hyperventilate to compensate for the metabolic acidosis. Does this make sense? I won't go into acid bases too much because I think everybody hates it, and it's not it's not a one episode type of thing. But basically, just remember that if an animal is super acidotic, they can often try and compensate by hyperventilating to, if you like, putting it simply, almost blow off the excess acid by trying to get rid of more carbon dioxide. So often your DKA cats can come in looking like they're struggling to breathe, but it's not actually a breathing problem. So if you do get a normal POCUS and you're not suspicious of airway disease, asthma, tumours in the chest, an upper respiratory tract obstruction, but you think, actually, this cat's been systemically not that well for a little while, or it's been drinking a bit more, or it's been weeing a bit more. At that point, I'd then do my bloods because I think maybe I'm missing something. I want to know what those electrolytes are doing. I want to know what my glucose is doing, and I want to stick a ketone stick. So it's just remember that you can get those weird and wonderful ones. Think outside the box. Is it actually a true dyspnea case? So, I mean, do you find those with your DKAs?
Well, yes, but you're obviously more sensitive to this than me because I know that DKA will cause them to breathe heavier. And I think you normally know from the history that they're DKA, whether they're usually diabetic or whatever. So I'm normally there. So it's normally for me the other way around. I've not had one present as dyspneic and I've gone through the whole workup and then gone, oh my gosh, they're actually DKA. But I've seen the respiratory change in my DKA patients. And yeah, if you're on the lookout for it, it's definitely there. Yeah,
Yeah.
it's a good one.
To to be honest, I have actually had it, I mean, it's always cats that I've had seen it in, but I have actually had a couple of cats where they've had no idea that it's diabetic, and the history doesn't give me any idea as well, because it's often those cats that love being outside. So they don't see them wee, they don't see them drink. They haven't noticed any change in their eating because they're hunters or whatever. And they basically just say, oh, it just came in, it looked a bit flat, and then it started breathing funny. And they're the type of owners where, because they don't see the cat a lot, they just don't tend to notice the change. And don't get me wrong, the cat will not look well. It's not going to be, looking systemically well when it comes in anyway. So you might be thinking, oh, what else are we missing anyway? But sometimes they can present as what looks like a dyspneic case. So it's just worth remembering. But anyway, like you say, normally owners are more on it. But
Well, yeah, or their GI. They're not eating, vomiting, diarrhea, so I think that takes me down. So I haven't had the specific situation, yeah, where I've just had the dyspnea, but I can see why you would get it. The
yeah.
commonest one I think to be wary of is cats when they get freaked out by something. They've had a fight outside, something's chased them for however long, they've belted in through the cat flap, the hair's all ruffled, they've got bits of whatever all over them, and they come in, they're hyperventilating from the stress, and you give them half an hour, or they're hit by a car cat that's actually not that injured, but it's open mouth breathing or whatever, and then
Mm,
within 45 minutes it's so much better and it's panic over. Isn't I'd say that's I know it's not quite it, yeah, that's another one to be careful about.
yeah.
And
Yeah, for sure.
the hypothermic or even pyrexic, actually, pyrexic cats and dogs, I'll often hear the chest sounds a little bit up, and I'll think, "Oh, is there a chest problem here?" And then I'll do the temperature, and it'll be 40.2. I'll go, "Ah, okay, I think this is a more likely a pyrexia than a primary, yeah, severe chest disease."
Okay, so where are we at? We've done our POCUS, so we've done our initial workup, if you like, and we've ruled out some of the really big things that we want to make sure we've ruled out. We've had a little think about, okay, are we missing something? Is there something else that we want to do from here? But I guess the only other thing to say is, yes, don't get me wrong, if you have a saddle thrombus cat, so if you have a feline aortic thromboembolism cat, yes, more often than not, they can also be in congestive heart failure or at least have evidence of an increased LAAO, even if they don't have many B lines. And sometimes you see that lovely swirly smoke in the left atria where you can see, oh, there's a clot lovely that's about to come forward. So sometimes you have a bit of an idea, but sometimes these patients, even before you've put a probe on, I think we touched on it in the last episode, but you're already pretty certain of what you're going to find before you have a look. So maybe we think about, if you've got a dyspneic presentation and you're suspicious of a saddle thrombus in a cat, what are we looking for as well here? And what do we do to diagnose that as well? So that sort of horrible classic yowling presentation, it's awful, isn't it?
Yeah, can we say a hats off to reception staff? Because experienced reception staff
Yeah.
will literally go, "You've got a salad thrombus coming in," because they'll have heard the cat in the background
Yeah.
with that awful, mournful kind of cry. The owner said the cat's off its back leg, sudden onset, and
Mm,
sometimes open mouth breathing, yeah, usually, yeah, you can almost diagnose them at that point, can't you? So I've had, by the way, you said I've had 3 cases. Have you had this as well, where it looks like a ping pong ball bouncing around the left atrium, the blood clot, like literally
yeah.
like a ping pong ball? Just terrifying but amazing.
Yeah.
Yeah, I diagnose them by looking for the left atrium enlargement.
Do
I mean,
you?
that's not okay. I use diagnosis in the loosest sense, but if they've got low rectal temperature, I can't feel femoral pulses, and they've got a massive knee, in my opinion, they'll have a very big left atrium.
Mm.
That's it. For me, I'm done. Yeah,
Yeah.
I don't do that. Look, I don't want to poo poo. What works in your hands, but I don't do that lactate da di da thing because
Yeah.
I can really quickly get big left atrium, no femoral pulses, cold rectal temperature.
Yeah.
I'm done.
Yeah. I think it's that in theory on clinical exam, it's that those P's, I can't remember whether it's 3 P's or 5 P's. It's like pulselessness, pallor.
Pain? I've never heard of this. Go on.
There's the P's, isn't there? I can't remember. It's
Panting?
going to be really, maybe, but there's all these P's, which is really not useful because I can't remember them. But basically, if you can't feel pulses in either hind leg, if both of those hind leg limbs are cold, it's got no sensation in either hind limb. So you pinch them and it's got no nociception, i.e. the cat does not respond, not withdrawal, that's different, but in terms of doesn't respond. So it doesn't turn around to be like, ouch, get off. And if it's got a really low temperature, for me, it's a FATE unless proven otherwise. And I think the only caveat I would say with the left atrium is that the majority of the time they get a saddle thrombus secondary to heart disease. But apparently there are cases where they don't always have to be. So you can have hypercoagulable states where they'll throw a clot and they don't always necessarily have to have heart disease. So that's the only thing that I will say. But I agree with you, to be honest. I think nearly every single one that I've seen that I have put a probe on, it's had a massive left atrium. So I think the majority of the time they do go hand in hand, but I wouldn't necessarily say it's not a saddle thrombus because it hasn't got a big left atrium. I think ultimately, if you're ever unsure, checking blood pressures on your legs, because obviously if there's no pulse, you won't get a blood pressure on the leg, or checking your glucose and your lactate, like they say to do. Yeah, it's really sensible. But ultimately, if you've got no nociception in either hind limb, but there looks like there's a suspicion of trauma and they're both still warm, then you're much more likely to think that it's a spinal issue and just sort of a neurological problem rather than a clot. I think for me, if there's no nociception in either hind leg, and especially if it ticks all the other boxes for a thrombus, I don't know what you do with these, Brendan, but I never attempt to treat them. I always euthanize them because I just don't think it's fair.
The first year I was at Vets Now was 2020. The ECC conference, they did a talk. Someone did a talk. It was a really good talk, actually. And he was saying that it is sometimes worth treating them. He said he made the point. Well, we treat major trauma. They're in loads of pain. We give them loads of pain relief. And we treat them. So fresh with enthusiasm from the conference, my first thrombus cat I had, I was like, okay, let's try and treat it, like they said at the conference, at the Vets Now conference. And the nursing team around me were like pretty distressed. And I ended up euthanizing it like 45 minutes later because it was also congestive heart. So therefore its breathing was not so great and everything. And so where I go now with it, because when I was in general practice, we certainly had 3 to 5 cases over that 9 years, which were more mild. So they were either more like one leg or not full occlusions. And we did treat them and they stayed in our hospital for a couple of days. We had them on bags of pain, but they weren't going into congestive heart failure. So they weren't respiratory and we had the pain well managed. So with the proviso that the patient can breathe well, the pain is not in awful pain, they're not complete loss of femoral pulses to both legs, I could make a case for being a bit more nuanced and saying, well, maybe this particular patient we can try. Because those 3 to 5 cases we did when I was in Bromley, they did really well. And I remember one of them was still doing well 3 years down the line. Obviously, you put them onto clopidogrel, possibly rivaroxaban, if they can afford it nowadays. Back then, it was clopidogrel and or pediatric aspirin.
Yeah, I think for me, because the majority of them, like you say, are going to be in heart failure as well. So for me, it's at that point, it's like, what is the point? Because even if you bust the clot, they're just going to get another one or they're going to get a pleural effusion or sort of what is the point of keeping going at that stage? I don't think it's fair on anyone. But especially if it is unilateral, I think the unilateral ones I'm more, and if you don't see anything on POCUS, if that heart looks okay, those are ones that I probably would refer because I'd say, okay, well, maybe there is an option, but it would have to be clients that are understanding that you could try a hell of a lot and it might still go horribly wrong. It just depends and it depends if it's like a really spicy cat as well. You think that is never going to tolerate being hospitalized and it's going to hate anybody touching it. It doesn't tolerate the pain. Like, it's very case dependent. So we've covered our FATEs, done our POCUS. Now we're on to is there any more diagnostics that we want to do to get a better picture? We've stabilized our patients as much as we can, but ultimately we need to know exactly what's going on so we know how to treat these patients. So I guess this is the point where we could talk about other things that you might want to do. Blood pressure is always one that everybody's, seems to forget really easily, but it's so easy. It's cheap. It's not invasive. Just get a cuff on it and just double check. Because if it's hypertensive, great, it's something you can treat. So it's worth checking.
This is one of your
And then,
rant issues, isn't it? You love a blood
yeah, no,
pressure.
I'm sorry.
You really
Yeah,
love a blood pressure. Oh,
yeah.
I hate
Well,
them.
yeah, I know. And I
And
think a lot of people
they're
do, but
fraught
I
with
just,
problems, aren't they? If they're high,
yeah.
what, you're that convinced it's hypertensive?
I guess it depends how high the blood pressure is. If a dog comes in and its systolic is like 150, 160, I'm not going to throw amlodipine at that dog. But if it's consistently 220, I will be saying, this dog is massively hypertensive. I don't want this to get problems with its sight, etc. Because because it's going to have consistently high blood pressure for such a long time. At that point, those are the cases that I'd be treating. But then I guess the only caveat to that is that sometimes the body's response will be to elevate the blood pressure as a compensatory mechanism. So you do have to be a little bit careful. But I just think generally with blood pressure, it gives you a fuller picture of what's going on. It's cheap, it's easy to do, it's non-invasive. Like, why not?
On Vin, Mark Rishnu is internal medic and cardiology, and he does some really good stuff about how inaccurate our blood pressure machines are.
Mm.
And he makes the point that there isn't a single veterinary, well, this is a few years ago, I think it's still the same. There isn't a single veterinary blood pressure machine that would pass the sufficient accuracy tests to be allowed to be sold for a human. Like our blood pressure monitoring equipment is so poor. So you've got that, plus you've got white coat effect.
Don't get me wrong, they have their pitfalls, but I just think we should be checking it more often. And it's something that's so simple and so easy to check and so cheap. So for me, it seems silly not to, but everyone has their thing. But the other thing that you'd want to think about in these patients is basic bloods. Now, obviously, what bloods you want to take depends on how your patient is presenting. But in an ideal world, for any dyspneic patient, if we all got really good at it and we all had EPOCs or whatever you're using, in an ideal world, we'd all take arterial blood gases because then we could interpret what their oxygenation is and what their PCO2 is doing and all that sort of stuff. But I think in reality, if you've got an EPOC or a sort of blood gas machine, venous blood gases will tell you a lot at this point anyway. And ideally, even if you can get a tiny bit of blood from your IV cannula, remember you can still do your basic minimum database, your glucose, your lactate, PCV, total solids, BUN. All of those things give you a hell of a lot of information really quickly. You could do a blood smear. So even with a tiny amount of blood, you can still get a lot of information. In an ideal world, if I'm in the emergency setting, what I normally do with these guys is if I have time, I do a smear, a PCV total solids, and an EPOC is what I'd normally run on these guys, which gives you quite a lot of information.
What am I doing in general practice? You don't get that many, do you? Yeah, often we don't have an EPOC. So, by the way, I personally think a venous blood sample and an EPOC on a respiratory case is more than enough. I don't know.
For me, the only difference that your arterial makes is your oxygenation. So if you're worried about how well the patient is actually able to oxygenate their blood, then obviously that's when your arterial blood gas comes into play more so, because you can't measure oxygenation from your venous very well. But
But
yeah,
what
I
about
think
your pulse oximeter?
yeah, your pulse ox. But then again, it's a typical bit of kit that's horrendously inaccurate, isn't it? Like your blood pressure machine.
Well, it doesn't work, I think. Yeah.
Yeah.
Well, it can be. It's reasonably accurate, isn't it? I don't know.
Yeah, I
But
think
the
it's
problem
one
is,
of,
it's just
yeah.
getting one on the non-anaesthetized patient is a nightmare, isn't
Exactly.
it? Yeah.
Okay, so we've thought about POCUS, we've thought about blood pressure, we've thought about basic bloods. I guess similar to your SpO2, get your multi-parameter hooked up. Even if the heart looks okay on a POCUS, can you get an ECG? What are you looking at? Get your SpO2, except if the patient is obviously, if they've got an ET tube in, then you want to get a capnograph on there, etc. So there's a lot more information you can get from those multi-parameters. And then I guess once you've done those things, if you still need to know more about what's going on in the chest, x-rays. And they are super useful, don't get me wrong, but only do it if you can do it safely, or ideally as safely as you can. So a DV when they're not stressed, fine, but you want to be doing all those other steps first before you go to pushing a dyspnea patient into lateral. So is that that's sort of the steps that you take, or do you rush to
Yeah,
x-rays a bit
and
quicker?
can I I love my 20-second ECG, lead 2. I just want to see, is there a P wave? Is there a QRS wave? Is there a T wave? I don't know. How many VPCs are there? I think it's amazing. And I had an amazing ECG result. About a year and a half ago, I had a animal. It was a cat. And the owner gave me the most vague sign. She went, the cat's just not right. I can't put my finger on it. He's eating. It's just not right. And I auscultated the heart rate at like 210 or something. The nurse also did it at 220, let's say, something like that. And this is the right order of events, I think. But I put the probe on, and it looked like the heart was buzzing, like a bee, like literally buzzing. And I was like, oh, something's not right with the electrical connection or something. It's the fault of the machine, but it wasn't. The heart was literally buzzing, right? And we put the ECG on, and the heart rate was over 300 and something. It was high. I can't remember what it was. I don't know, 350 higher. And so it just looked like the heart was vibrating because it was so fast. And yet the auscultation didn't get me there. And it's another one of those little things, that ECG. So when we put the ECG on, then we got the exact number and, and what was going on. Obviously, it's a tachyarrhythmia. But there's a tachyarrhythmia. I didn't even suspect it from auscultating the heart.
Yeah. Yeah. Yeah.
Yeah,
Yeah.
so I love that ECG. That doesn't happen that often, but ECGs, I think, even a 10, 20-second one, it's easy to do.
Yeah. 100%. Yeah. Cheap as well. Hey. So.
Yeah, I think people are scared of interpreting them, but I think in a merge, we don't try and be that clever, do we? We're going to look for the things we know about, and if it's anything else, we don't have to get involved. So
No.
if it's got wide ventricular
Bizarre.
VPCs, yeah,
Yeah.
and and its heart rate's 260, great. We can go VTAC. If it's super slow, similar, is there P waves or whatever. Yeah, it's just simple things. We don't have to do the full thing because it's just
Yeah.
enough to direct
100%.
us.
Yeah. And if you're ever worried, get a book out. Get a book out and look at the waves in comparison to what you're looking at. I know I do that sometimes. So, okay. So we hopefully by this point in our stage with this patient have got to the point where we've got a pretty good idea as to what's going on. We might not have all the answers, but hopefully we've got enough to be able to start treating. So I think at this point we need to dive into a little bit of treatment. What are we going to give them? What are we going to do next? So I guess one of the biggest hitters that we're going to see most commonly with our dyspneic patients is cardiogenic pulmonary edema. So those patients that have CHF, so they're in heart failure, and you sort of done your POCUS, you know that that's going on. They've got an increased LAAO and they've got B lines all over their chest. So what are you giving these patients, Brendan, as first line?
Yeah, or they're a cat with a pleural effusion and we've drained their chest and
Yes.
we've got 180
Yes.
mils of fluid out or whatever, and it's zero sanguinous, it's a bit reddy, watery
Yeah.
typically, or just pure water. So, yeah, I think me and you do the same nowadays. Reasonably lowish doses of frusemide, but I just do
Mm-hmm.
the frequency higher if I'm not
Mm,
getting a nice response. So I might even go as often as, well, for me, maybe every hour.
mm.
So like the kind of 2 to 3 or even 2 to 4 mg per kg dose, ideally IV, but yeah, if I've got IV access. How's that
Yeah,
sound compared
exactly.
to you?
Yeah, I think the same for me. I mean, to be honest, obviously check if it is a known cardiac patient, check if they're on any medications already. But for me, with these dogs and cats, I generally start at 2 mg per kg and I just give the boluses really often. So, especially the really dyspneic ones, I actually go as often as every half hour. And obviously, don't get me wrong, if I've given 3 doses and it's not responding, then I won't be thinking, is me giving repeated furosemide actually going to make any difference? But sometimes you need to give it that frequently to start off with for them to start responding. And then obviously once they do start responding, then reduce down your frequency. So you could then do it once an hour, once every couple of hours, etc., until you get to the point where they're no longer dyspneic. I guess the only caveat to that is obviously if you haven't managed to get a blood sample beforehand, what are the kidneys doing? Are you making them way worse? And I guess if they are super dyspneic, if you can get enough blood to check their kidney values before you start loading them with massively high doses. The only reason why I say that is that I have had a few where they've been massively azotemic before you even start. And I think those cases, sometimes I'm speaking to the owners and saying, look, do you even want me to keep going? Because you're going to bugger their kidneys. You might stop them from being dyspneic, but if they go into renal failure because you've given them so much furosemide, it's sort of what was the point? So that's the only caveat I'd give.
Yeah. And obviously we're pushing the potassium down there as well, so it's another thing.
Mm.
Yeah, maybe say, after 24 hours or whatever, we might want to keep an eye, where's the potassium, because that frusamide's going to knock that down a bit.
Yeah,
especially in the older
100%.
cat that's, yeah, a little bit inappetent. Potassium's already going to be a little bit on the lower end.
Yeah. Yeah. And I guess you're probably more used to using it in GP practice as well. But in those cases where you've got them on furosemide, but they're refractory to it, there's the other drug that you can use, isn't there? I don't know if you use it quite often in GP world.
Yeah, it's there. Torsemide. Torsemide? Is that how you say it?
Torozamide or something like that. Yeah,
Torsemide?
yeah.
Oh, yeah, there you go. Yeah, I've seen it on the shelf quite a bit, actually. 5 years ago when I left general practice, it was a bit of being a bit clever. But I only ever used it in the context of frusamide's no longer working. Now we're
Mm,
reaching for that. And in that context, it wasn't a wonder drug at all. Nothing much
yeah.
different really happened. I don't know. Um, now, there was something in the ACVIM consensus about this, wasn't it? But it's still not a first line diuretic, is it?
No, I think I only ever use it for if they're not responding to furosemide anymore. It's something that I jump to afterwards. But if I'm jumping to torozamide, I'm chatting to the owner and saying, we are getting close to the end, because if they're not responding to furosemide, it's not going well.
Should we have a shout out to furosemide as well, in that it's way more than just a diuretic?
Yeah.
Yeah, I think, so it's anti-inflammatory. I think, it has beneficial effects on the heart as well? Does it reduce afterload? Or I'm
Uh,
forgetting, I'm having to reach for my notes now to remind myself. So there's effects on venous dilation, there's anti-inflammatory effects, and there's also its diuretic effects. So
okay.
it is a bit cleverer than it's been made out to be.
Yeah, I think the one thing that I would say is that if you're trying to get rid of fluid that's not cardiogenic in origin, then furosemide is not the thing that you want to use in terms of getting rid of that fluid. That's not how it works. But if you're wanting to use it for these other things that you said, potential anti-inflammatory properties or bronchodilator or whatever else it could be doing, then, yeah, great, maybe it is a good idea.
I agree. I do only use it in the cardiogenic cases,
Yeah,
for
perfect.
sure, and I'm with you there, but it has these other effects that are worth bearing in mind, and it's not just
Yeah.
a simple diuretic.
Yeah. So if we're sticking to our CHF cases, the other big drug to think about is pimabendan. So we obviously all know it's an inodilator and it can work really, really well. So in your suspected mitral valve disease cases, or in cases where where their cardiac contractility just isn't that good, it can be a really great drug in our arsenal. But there's one thing that we have to be really careful of with it. And that if you've got a patient with is it left ventricular outflow tract obstruction, you cannot use pimabendan. It's contraindicated. And I guess that this is the only thing that I worry about with those basic T POCUSes that we do, is that we're not cardiologists. I can't tell on a scan if something's got an outflow obstruction. I can't tell that. But if you're that convinced that it's probably not, then I think it's still a great drug that we can be using, but you just got to be that bit more careful. Does that make sense?
I tend to use it. So normally the context I've used it is cats, and they're having their second pleural effusion, and it's 2 months after the first one. And you know that you can't keep draining a pleural effusion. So it's in that context where it's, what you can do, euthanize, or you can do some pimabendan. And I must say, I've done it about 3 times now. I think the first time was a vet nurse's cat, and both times actually, the clients were, where I got really good follow up. The clients were amazed. The cat was like so much brighter and better. Bit like dogs when they
Really?
start vet medding, and I think the owners are
Yeah.
like, "Oh wow, they're so much better so quickly." I think again, pimabendan has kind of more effects beyond just the inotropy. I think, there's a little bit of a pick me up effect as well. So yeah,
Yeah.
it's such a shame in a way that we can't rule that out, because I think a lot of cats would benefit from pimabendan otherwise.
Yeah, I think it's a drug that, to be honest, I probably am a bit lax with it and sort of don't really worry and just use it. The only thing that I hate about it is when you use it in the emergency setting. If you have to use IV because you've got a dyspneic patient, it's so expensive. Oh my God, it's so much money. Especially if you have a big dog, it's like 300 quid per injection or something ridiculous. So yeah, have that discussion with the owners in terms of cost before you give it. But otherwise, I think absolutely do. It's great. So in terms of treatment, we've gone through roughly what you do for a CHF patient. The only difference is that obviously in a cat, if you've got a pleural effusion, or any pleural effusion really, you also would have to do therapeutic thoracentesis. But that's also part of your diagnostics as well, because when you've taken that fluid, you can then sample it in-house and say, okay, what fluid are we dealing with? And like you say, if you have that like modified transudate that's like a little bit bloody and it's got no other really real cellular content, then obviously CHF is much higher on your list. Whereas obviously if it's full of neutrophils and intracellular bacteria, you've got a pyothorax, for example. So your thoracocentesis or your pericardiocentesis is going to be both diagnostic and therapeutic. So that's worth thinking about. And in terms of treatment, it's going to help you. So same
Yeah.
for
And I was
pneumothorax as well.
Well, yeah, and I was just thinking with the cats with the pyothorax, sometimes you have to put a bit of warm saline in there, don't you, just to dissolve
Mm,
and loosen up the pus, and then it starts to drain better. Or sometimes they just need a chest drain, and that's wider bore, and you'll get that pus
yeah,
out because you are going to be doing these multiple times, I'm assuming. At least my
yeah,
pyothorax
100%.
cats I have. So
Yeah.
a chest drain's kind of fitting in once they're steady or stable enough. And
Mm,
I'm using a bit of warm saline to, and then like tapping, mixing it up with the pus. I don't know,
yeah.
waft them around a little bit, and then the
Yeah.
pus comes out. Yeah, same for
Yeah,
you.
exactly. Yeah, but I think, to be honest, even before you get to that point, if you're convinced it's pus from the small sample that you've got, have a chat with your owners, talk about are they wanting to go for a GA, bilateral chest drains, extensive hospitalization, because you're in that realm of things then. And if they're not keen or they don't have the money, you've got your answer at that stage anyway. So even before you get to that point, I think it's worth taking that little sample that you've got to confirm it and then make a plan from there. But okay. And then I guess obviously we can then talk about our trauma patients and stuff as well. The thing is trauma patients is going to be completely dependent on how they are. Like I say, you might have a pneumothorax, but it might not need draining if they're not dyspneic. You might have pulmonary contusions, but pulmonary contusions will heal on their own. They're bruising. The only thing you need to remember with that is your fluid rates. So please, once you stabilize them in terms of shock, don't keep flooding them with fluids because you'll make the contusions worse. But yeah, trauma is one of those things where you've just got to treat what's in front of you and go step by step, really, haven't you? We've probably only got a couple more big ones to talk about. The next one, I guess, is feline asthma. So, in terms of emergency sense, when they come in dyspneic, what are we using sort of first line for these guys?
Wow. Well, I'm getting an IV cannula in them, IV Dex. There
Hmm.
was times where we used to have the Ventolin inhaler, and we used to have a little practice Aerocat. So we could we'd give them that as well, and we'd also give them that what's that? Remind me, the injectable terbutaline, is it?
Sabutylene. Yeah. Yeah. Bricanyl. Yeah.
Bricanyl, that's it. Yeah, I mean to some extent, IV Dex gets you there, doesn't it?
Yeah, yeah. So I guess doses wise, you want to go for terbutaline 0.01 mg per kg IV or IM, and you're using that as your bronchodilator, and you can repeat that every 4 hours. And I guess your IV Dex obviously do as you need, but I think your normal anti-inflammatory dose is probably what I'd suggest.
Do you know what? They're okay, aren't they, asthma cats? They look
Mm.
awful. You give them a little whiff of treatment, and they're better.
Yeah, yeah, they can be really nice. The other one before we go on to the biggie, thinking about BOAS patients, generally first line in terms of aspiration pneumonia, if we're pretty convinced, I think for me, I'm reaching for Coamox IV, so amoxiclav, and generally I'm going for like a 20 mg per kg dose at every 6 or 8 hours IV. I don't know if you're using the same.
Yeah, penicillins and the cephalosporins, I think they're time dependent. So the more frequent you do them, the better they are.
Hmm.
Depending on how critical my patient is, I'll certainly go to 6 hourly, or more, so to have the maximum effect. Because they're often young patients, aren't they? They're in a bad way. So yeah, I really go for it.
Right, I feel like we need to move on to probably the biggie in terms of the one we all hate treating, your upper respiratory tract obstruction. So we're talking pharyngeal paralysis, but your BOAS patients. So I guess your milder ones, yes, you could reach for your Torb. And I think we both sort of would normally do what your point 0.3 to point 0.4 mg per kg, something like that in these guys. But to be honest, usually the majority of BOAS patients that we're seeing need quite a lot more than Torb. So I don't know about you, but I reach for medetomidine in these guys so often because they just need to be chilled out. And I think actually, even if worst case scenario, the medetomidine makes them get to a point where they can no longer breathe on their own, to be honest, if they're having a true BOAS crisis, you're probably not far off of needing to induce anaesthetic to tube them anyway, in which case it sort of just pushes you towards that point a bit quicker. Um, okay, sometimes you are just needing to tube them. And I think when you get to that point, giving them a slug of propofol, getting a tube in, and then keeping them on a propofol CRI.
Yeah, go. I mean, yeah. So I mean, if I had a cyanotic bulldog that was hypothermic, I would be probably intubating, propofol, CRI, and intubate. And then those cases that I propofol, CRI, I will then, you've got that point where you want to get them off the propofol, but you don't really know how they're going to do. That's the context where I've used medetomidine. I put a medetomidine CRI, so it's much more gentle and titratable. But at that point, because they've been essentially anesthetized, it's a calmer situation. Things are more stable. And now I've got my multi-parameter monitor, and I've got my nurse ready to monitor, and I've got my medetomidine CRI. So everything's kind of under control, if you like. Whereas I would find when they first come in and it's all a little bit, everything's changing all the time and you don't really know how the patient's doing, that's quite a scary time for me to do medetomidine. I think if I were to do it, I would probably not go IV. So you can you're introducing it more gently into the patient.
My thing is that if they're blue and they need intubating, they need intubating. So just give them prop and intubate them. If they're not blue and you can tell that they're just doing that typical brachy thing where they're just completely panicking, that's when I like medetomidine. But I agree. I think when you're bringing them round, the last thing that you want to happen is extubate them start to wake up, they panic again, they get back into the cycle of the crisis, and then you just go back to having to re-intubate them. So that's when your CRI can be fabulous and it works really well. Maybe the very last thing to cover is, I think we all hope and pray for the day where we can do that superhero thing. Have you ever seen that video where you get the dogs where they have the ball stuck in the back of their mouth? And you do that Superman trick where you have to flip them on their back and put your fingers up underneath their jawline and push, and it just pops out. Like, honestly, I think I do actually pray that one day I get to do that, because I think it would be, well, obviously not cool for the owner or for the dog, but like, how cool to be I just did that. That was amazing. You've done it.
I've had 3.
No way.
Yeah. Did you not know this? Yeah. I've had some cool ones.
Superman, Brendan.
Well, I didn't look. No, actually, I did them all wrongly. Yeah. Should we go in? I don't know if we should go into this. This is confessions of a useless vet, isn't it?
No, not at all. So.
Yeah. Well, my 3 cases, none of them were like that, to be fair. But I don't know if I was just very lucky with those 3. Maybe the other ones would have all died before they. No, but I haven't even seen one die. So I do think there's enough space for them to breathe around actually quite well. And I base that on having one dog have the ball stuck in there for hours. But anyway, that's another story. I'll go into that another day. But right. So what I did wrong was I thought, right, I'm not going anywhere near that German Shepherd. It's scary. I gave it medetomidine. So I thought I'll sedate it a bit, then I'll do it. But after I sedated it, I thought, oh crap, what if it vomits? And I was shitting myself. It didn't vomit. And I popped the ball out using the technique.
I think realistically, you're in a bit of a rock and a hard place anyway, aren't you? I think if you're justified to use it, maybe next time warn the owner about the risk of vomiting. But I mean, how many dogs specifically actually vomit on medetomidine anyway? I don't see that many, to be fair. So cats, yeah, but I don't actually see that many dogs. I know it's a risk, but I don't necessarily think, I think you did the wrong thing there, to be fair. But there we go. Okay, so I think finally we've got roundup time. So over the last couple of episodes, we've covered everything that you could, well, hopefully, most things that you'd come across in a dyspnea case, from emergency stabilization and clinical exam to workup, differentials, and different treatments that you could consider. It is impossible to talk about every case that you might see, but generally, I guess, in terms of take-home messages for dyspnea, stay calm, oxygenate your patient, minimize stress. Let your physical exam happen once you've minimized stress, and then POCUS to guide you to the cause. And then if you're still not sure what's going on after that, look elsewhere. But generally, if you can get through those things, you've done pretty blooming well.
So so look, if you've got questions, definitely send us any questions you have, whether that's on Spotify or Facebook or whatever, and we'll try and answer you. And if there's anything we didn't cover or anything else you want to go over, just give us a message. It'll give us inspiration for what to cover on these podcasts.
Yeah, absolutely. We'd love for you to get in touch. But for now, thank you for listening. We hope you've enjoyed the episode, or both episodes as it's turned out. And join us again next Sunday for our next 2-week takedown, where we'll be covering topics such as allergy testing, euthanasia protocols, and steroids. So until then, it's bye from me.
And bye from me. Take care. The content presented in the Chatty Vets podcast is intended for licensed veterinary professionals and is for informational purposes only.
Views expressed are those of the host and guests and do not substitute for clinical judgment or individualized patient care.
Drug dosages, protocols, medical advice discussed should be verified against current literature and manufacturer's guidelines.
Class and its creators are not liable for any errors, omissions, or adverse outcomes resulting from the application of this information.
Always consult relevant laws, regulations, and institutional policies in your practice. Listener discretion is advised.